Jacob and Lydia are responding to a report of a child drowned in a backyard pool. When they arrive, they see only CPR on a toddler. The initial report from the family members that the child was not seen for 5 to 10 minutes before being discovered on the bottom of the pool. The patient was pulled from the pool, and a family member immediately began CPR. So, what are some ways in which this incident could have been prevented? All right. Or they just walk out violence. Lock the door. Fences around pools. A lot of homeowners insurance will not cover you if you have a fence around your pool. What kind of factors are going to influence the patient's chance of survival? Okay. What else? Okay. Okay. Does the type of water matter? Alright. Patients in such incidents need emergency medical care as rapidly as possible. However, the circumstance in which they receive injuries can expose medical personnel to the risk of injury. Caring for these patients requires not only emergency skills, but also the ability to recognize and avoid potential hazards at the scene. An adult can actually drown in just a few inches of water. Infants often drown in 5-gallon buckets. Others drown in bathtubs and toilets. Common sense precautions include all pools should be fenced. Children should be under constant supervision if they are near a lake, pool, pond, or a container of water of any significant size. Water activities and alcohol do not mix. Life preservers or personal flotation devices must be worn when boating. Avoid diving into shallow or unexplored bodies of water. Those with seizure disorders must be especially careful when around bodies of water. They can have a seizure and actually go under. Alright, regardless of the outcome, it is termed a drowning. Many sources, however, continue to refer to the patient who survives the submersion as a near drowning event. In the adult patient, consider the following conditions that may have led to the submersion. Hypoglycemia. Did they have a heart attack? Maybe from exertion. Any kind of cardiac dysrhythmia. Do they have a syncopal episode, seizure, depression or suicide attempt, anxiety, panic disorder, arthritis, Parkinson's, or any other kind of neurological, neuromuscular disorder? Exhaustion, hypothermia, alcohol or drugs, and trauma, especially head or spinal trauma. Water sports also pose a hazard of submersion and drowning. The use of alcohol and drugs can impair judgment and lead to boating and other water-related accidents. Jet skis, water skiing, and surfing can cause head and spinal trauma, leading to submersion and drowning. Scuba diving accidents from exertion, inexperience, panic, and poor judgment can also cause drowning. Alright? Panic. It's usually what people do. They panic. Often contributes to the death of the person who loses self-control. Okay? That's what we do when we feel like we can't breathe. Panic. It's a ingrained human. Quick rescue from the submerged patient. Of the submerged patient from the water and early resuscitation are the most critical factors associated with better outcomes. No single individual characteristic has been found to predict survivability. Moderate body core hypothermia associated with submersion can provide a protective mechanism that reduces brain or other organ damage in kids. However, most people do not become hypothermic quickly enough. Right? As the person is submerged in water, he attempts to breathe, and either they aspirate the water in their larynx, spasms, and causes them to suffocate. The most significant consequence of a drowning is the lack of ventilation while submerged, which leads to severe prolonged hypoxia and the accumulation of carbon dioxide in the blood, which can lead to severe acid buildup in the body. In a dry drowning, laryngeal spasms prevent water from entering the lungs. When water does enter the lungs, the amount is small, and it is usually absorbed into the bloodstream. The factor that has the greatest impact on the patient's prognosis is the duration of the submersion and the consequent severity of hypoxia. If surfactant, that's that stuff that's in your lungs is washed out. The alveoli tend to collapse. This is known as atelectasis. The damage to the alveolar capillary structures creates a ventilation problem by decreasing functional lung volumes and allowing fluid to leak around into the alveoli, which creates pulmonary edema. The alveolar capillary damage also interferes with gas exchange, impairing oxygenation of the blood and offloading of the carbon dioxide. A patient who is breathing spontaneously but has signs or symptoms of respiratory distress or hypoxia can benefit dramatically from CPAP. If CPAP is not available, consider early positive pressure ventilation with a bag mask device. Maximize the oxygen delivered to the patient by applying a non-rebreather mask at 15 liters per minute in the patient who has an adequate respiratory rate and tidal volume. This is the only time you will do that. If positive pressure ventilation is performed, be sure to connect oxygen to the ventilation device and deliver the highest possible concentration. Primary hypothermia can provide a role in protecting tissue against hypoxia. In other submerged patients, a secondary hypothermia can occur from heat loss through evaporation after the patient is removed from the water and resuscitation is attempted. Secondary hypothermia plays no role in protecting the patient against hypoxia and can cause further detrimental effects on patient outcome. Hypovolemia can occur during and after the initial resuscitation period from an increase in capillary permeability. Reducing hypotension. This can become especially evident when the patient's body begins to rewarm, causing the vessels to dilate. Dysrhythmias result from hypothermia and cardiac hypoxia, as well as from an increased amount of acid or a disturbance in the blood or in the balance of electrolytes in the blood. Alright, some of the most important signs and symptoms that you need to be aware of that determine the seriousness of a drowning event. Persistent cough, dyspnea or apnea, altered mental status, vomiting, drug and alcohol use. Alright, do they have a seizure disorder, diabetes, or neuromuscular problem? Hypothermia, duration of cardiac or respiratory arrest, the age of the patient, and any kind of pre-existing diseases or conditions. Patients who dive into water from a diving board, shore, poolside, boat, or dock often sustain injuries to the head and spine and fractures to the arms, legs, and ribs. You should always assume that a diver has sustained neck and spinal injuries, even if they are still responsive. Alright, do not let your desire to provide these simple life-saving measures overwhelm your judgment. You can easily fall victim to the same hazard as the patient. Remember that water can conceal many hazards. Holes, sharp drop-offs, and underwater entanglements such as fallen trees, wire fences may not be visible from the shore. Currents and streams, rivers, and storm drains can easily overpower the best swimmer. Okay? You only need to attempt rescue unless you meet all 4 of these criteria. You're a good swimmer. You're trained in water rescue. You're wearing a personal flotation device. And you are accompanied by other rescuers. Alright? Because remember, the first rule of EMS is what? Your own safety. Okay? Make sure you have a firm, solid footing and can't slip into the water. Try to reach the patient by holding out an object for them to grab. You can use an oar, branch, fishing pole, towel, shirt, or other strong object that won't break. When the patient has grabbed the object, pull them to shore. If the patient is responsive but too far away to grasp an object you are holding, another way of reaching them is to throw something. The best thing to throw is a rope. An EMS unit whose territory includes bodies of water should carry 100 foot of polypropylene rope and a throw bag. Okay. Make sure you have a firm, solid footing and can't fall in the water. Tie a long rope or line to an object that floats and is heavy enough to throw. Throw the object underhanded to the patient. When they have grabbed the floating object, pull them to shore. If the patient is unresponsive or out of reach, you need to either row to them in a boat if one is immediately accessible, or go to them by wading out, swimming, or using a float board. Your backboards do float, by the way. have body water, we ain't got no roads. Alright? So, if you can row out to them, that's all well and good. Don't try to swim to them, okay? If the swimmer might have been involved in a diving accident or have been struck by a boat, water ski, surfboard, or other object, you should suspect a possible spine injury. You should also suspect a spine injury in any swimmer or diver who has been diving and using a water slide and is suspected of being intoxicated. Has evidence of traumatic injury. The goal is to support the back and stabilize the head and neck as other care is given. It is important to stabilize the patient properly in the water and then remove them carefully from the water if possible. And if it does not pose a hazard for the rescuers, for you. If the patient is in swift moving water or a body of water with waves, attempting to secure the patient to a backboard is not feasible and can likely put the rescuer in jeopardy. In this case, remove the patient from the water and apply spine motion restriction after they are removed. When the face of a human or any mammal is submerged in cold water, the larynx spasms. Breathing is inhibited and the heart rate slows and the blood vessels throughout most of the body constrict. Does anybody know what this is called? It's right there on the screen. It's the mammalian diving reflex. Alright, blood flow to the heart and brain, however, is maintained. In this way, oxygen is sent and used only where it is needed to immediately sustain life. The colder the water, the more oxygen is diverted to the heart and brain. Patients who have been submerged in cold water, even after 30 minutes or longer in cardiac arrest, can be resuscitated. As a guideline, you should attempt resuscitation on any pulseless, non-breathing patient who has been submerged in cold water. Okay? You're not dead till you're warm and dead. Okay? That's the saying. Whether you're in water or not. Like, if you pick somebody up, if it's below freezing outside, pick like a homeless person up or whatever, they've been outside all night, they're not dead till they're warm and dead. You have to get their core body temperature up. If you choose to go in the water to rescue a patient, be sure you can swim and do not put yourself in danger. Make sure to take appropriate standard precautions because drowning patients often vomit. Decide if you need any additional assistance, such as a dry team to work on shore and a wet team to secure the patient in the water. Be aware that rescuers in white water or swift water require specialized techniques and training. We'll not be teaching those in this class. If the patient is found face down and a spine injury is suspected, work with your partner or partners, if possible, to carefully turn the patient over while maintaining manual inline stabilization. Suction water, vomitus, and secretions from the airway. Insert an oral or nasal airway if the airway cannot be managed with manual maneuvers. Patient with spinal injury often do not breathe if they have a high cervical injury. Assess for any open wounds to the chest that would seriously impede breathing. Any patient who has been submerged should receive a high concentration of oxygen because of the potential for pulmonary complications. If signs of severe hypoxia are evident, you want to think about CPAP or positive pressure ventilation with supplemental oxygen. Check the circulation to make sure the patient has a pulse and no life-threatening external bleeding that needs to be controlled. Patients with high spinal injuries affecting respiration who are found in respiratory distress or who are unresponsive are a high priority transport. Perform a rapid secondary assessment if the patient has an altered mental status or is unresponsive. Also look for evidence of possible injury. If the patient is alert, obtain a history from the patient. If they have an altered mental status, attempt to collect a history from relatives, friends, or bystanders at the scene. Most of the time, they don't know anything about them. For water-related emergency patients, look for signs and symptoms of any listed injuries or medical problems. Any kind of airway obstruction, absent or inadequate breathing, pulseless, spinal injury, head injury, soft tissue injury, musculoskeletal injury. Drowning patients can be unresponsive, not breathing or pulseless, and they can be responsive and possibly gagging or coughing up water. Okay? Your secondary assessment should be able to find external or internal bleeding, shock, hypothermia, alcohol, drug abuse, drowning, or drowning or submersion. Asymptomatic. Patients display no no signs or symptoms of the drowning event, okay, they still need to be transported. Symptomatic, they have altered mental status, can be as slight as just confusion. They'll have altered vital signs, tachycardia, bradycardia, tachypnea, bradycypnea, and hypothermia. Respiratory distress, respiratory arrest. Their respirations can be agonal. Dyspnea, no matter how slight, the patient is considered symptomatic. SpO2, less than 94 with or without oxygen support. And SpO2 reading can be difficult to obtain or be low if the patient is hypothermic. Persistent cough, wheezes, crackles, decreased body core temp, which is hypothermia, cool or cyanotic skin, vomiting, diarrhea, or both. Alright. They can be pulseless, apneic, and they can be obviously dead, which is they have signs of rigor and dependent lividity. Alright, Jacob directs another rescuer to take over CPR from the family member and quickly verifies the absence of a pulse as the switch is made. Lydia makes observations of the scene to determine if there are any mechanisms of injury or important factors to consider. She questions family members to try to determine exactly how long the child was submerged and to find out about the child's medical history. So, what are the steps in managing this patient? Anything going to be different than your normal CPR AED? Okay. You want to put them on a backboard and all that good happy stuff? Yep. Okay. Oh.
Stop CPR to quickly get them on the backboard.
It don't take 10 seconds to put them on the backboard. And a lot of times, we work codes anyway, and a lot of times we do that in stable service. That's something that you'll kind of learn, you know, A, it makes it easier for people. B, even in like hospitals and nursing homes, they have what's called a CPR board. It goes from about here. And instead of when you're on the bed, you know, you have that mattress. So this makes a hard surface for you to actually do compression on.
Do you ever, like, if you have a patient who's on a bed or a couch or something that's going to be critical, you always take them off that CPR?
Yes. Yeah, you take them off. Yeah, put them on the floor. If we have the option, I'll go ahead and put them on the backboard. I'll take them off the couch, put them on the backboard, and drop them on. Work smart, not hard. Okay? Alright. If you suspect that the patient has a spinal injury, maintain inline stabilization and then secure the patient to a backboard before removing them from the water if possible, and it doesn't jeopardize the rescuers. Alright, so water rescue with possible spinal injury. This is kind of sort of how you do it. Alright? You want to split the head and neck with the arms. Your arms, roll the patient over. Ensure the airway and breathing. Alright? See, Holtator in the back, he's got the backboard. He's like Mighty Mouse coming to save the day. Alright? Holtator number 1 is giving rescue breaths. Holtator number 2 is sliding that backboard up under him. And it's a whole lot easier when they're in the water because you can push that backboard down and just slide it up under them. Alright? And usually those backboards float. Okay? So you're going to float the board to the pool side and remove the patient from the water. Alright, if you do not suspect spine injury, place the patient on their left side so that water, vomit, and secretions can drain from the upper airway. You need to be prepared to suction as these patients will often have water in their airways and tend to vomit because of the water that has been swallowed. If the patient is in respiratory arrest or is not breathing adequately, establish an airway and provide positive pressure ventilation with supplemental oxygen. After you have determined that there are no foreign objects in the airway, provide ventilations. With increased see the patient's chest rise. Alright? If the patient breathes spontaneously and adequately, administer high concentration of oxygen to any submerged patient because of the potential for pulmonary complications from aspiration of water. Your lungs do not like water, okay? It washes that surfactant out, and it makes it a whole lot harder for us to breathe, alright? Apply a normal breather mask and set the oxygen at 15 liters per minute. You want to consider CPAP. If the patient is pulseless and apneic, begin CPR, apply the AED, and proceed with that protocol. When gastric distension reaches the point at which it interferes with the capability to ventilate the patient, place the patient on their side. With suction immediately available, place your hand over the epigastric area of the abdomen and apply firm pressure to relieve the distension. It's like burping them, but not. But it is. It's like burping a baby, but not really. Okay. Do not apply the Heimlich maneuver as a routine in the submergent or drowning patient. It can lead to vomiting and aspiration. Manage any other medical or trauma conditions associated with the drowning event, such as soft tissue injury, seizure, or diabetic emergencies. Transport the patient as quickly as possible, continuing resuscitative measures en route. Approximately 15% of all drowning-related deaths result from secondary complications. During transport, you should keep an eye on your patient. Okay? Keep the patient warm and continue to provide high concentration of oxygen. Complication can arise up to 72 hours after the event. Be alert for signs that the patient is deteriorating into respiratory cardiac arrest, especially if you have already previously resuscitated this patient. You may not practice as an EMT in or around oceans, but accidents involving diving can occur anywhere. Many people dive in quarries, lakes, rivers, and caves. Dyspharism is a medical condition that results from the effects of the body of changes in ambient pressure. The pressure change occurs when a person descends in water or ascends in altitude. Recreational and commercial divers, when descending into depths of water, experience a drastic increase of pressure on the body. This pressure affects only the compressible structures and substances within the body. The gas contained within the organs dissolves in the blood and is found in hollow spaces and compressed and is affected by the changes in pressure. If the diver breathes in compressed air at a depth where there is a higher pressure on the body and then suddenly ascends, the volume of air in the lungs rapidly expands because of the decrease in pressure as the diver comes up. This can lead to barotrauma or rupture of the alveoli and other lung structures. If you ever go diving, I would not suggest doing that. Alright, Dalton's Law. As the diver goes deeper underwater and the pressure in the inhaled nitrogen increases, the nitrogen begins to dissolve in the blood. Other gases in the mixture of inhaled air do not have this action. It's just the nitrogen. Nitrogen in the blood affects the electrical properties of the brain and produces a nitrogen narcosis with similar effects to anesthesia. I don't know why we don't just give people high on nitrogen and operate on them. That's, yeah. Why give all these drugs and stuff? Just, hey, I'm not really sure how expensive nitrogen is. This drugs used for anesthesia is pretty expensive. As noted, when a diver descends, the pressure increases. The nitrogen inhaled tends to dissolve into the body's liquids, mainly the blood plasma. It then also begins to dissolve into and accumulate in the body fat and tissue. If the diver then ascends too quickly, the dissolved nitrogen returns to a gaseous state while it is still dissolved, causing bubbles to form in the blood and the tissue. This is no bueno. Okay? So, Charlie's Law. All gases expand equally upon being heated. Alright, these laws all contribute to the conditions the diver can experience while descending into or ascending from deep water. Yes. Decompression sickness, also known as diver's disease or the bends. Alright, is a condition caused by dissolved gases coming out of solution to form bubbles inside the body on depressurization. I've never had bends, but I've heard that it's pretty freaking painful. And once you have it, you don't ever want to have it again. Anybody in here ever had bends? They say it's pretty rough. Bubbles can cause coagulation of blood to occur. In response, the vessels and surrounding tissue release substances as they would in an allergic reaction. These substances produce signs and symptoms similar to those of an allergic reaction. Factors that increase the risk of a patient developing decompression sickness: flying or going to high altitudes too soon after a dive, usually between 12 and 24 hours. Failure to take the necessary safety stops while ascending from a dive. Inadequate surface intervals. Inadequate decompression. Diving at depth for too long of a period. And repeated dives at the same depth on the same day. Physical characteristics or conditions that predispose an individual to decompression sickness. Poor physical condition: obesity, nitrogen, dissolved easily in fat. Well, I'm screwed. If you're diving. Age, screwed again. Dehydration, once again screwed. Heart or lung disease, pre-existing musculoskeletal injury, and fatigue. Well, I'm just screwed on all aspects of these. Guess what I'm not doing for vacation this year? Environmental factors can also put the diver at risk for DCS. Alright, decompression sickness. Alright, the pain characteristically associated with decompression sickness has been given this disorder its nickname, the bends. It usually results from a diver ascending too rapidly. As noted earlier, gases, typically nitrogen, form bubbles. It's not good. The onset of this can occur up to 72 hours following the dive. Pain is the hallmark symptom. It is seen in approximately 70 to 85% of patients with type 1. Alright? It's typically a dull, aching, throbbing pain, usually in the joints or tendons. It can also be in other tissue. The shoulder is the joint in which is most commonly experienced the pain. It typically begins as a mild or not severe, and then gradually intensifies. Many divers initially think that the pain they experience early on is due to a pulled muscle or overexertion. Type 2 is more serious than type 1. Well, that makes sense. The patient experiences more significant signs and symptoms, however, they can be diverse. The onset of the signs and symptoms is usually immediate, but can be delayed up to 36 hours after the incident. They have low back pain that progresses to paresis or weakness, paralysis, numbness or tingling, loss of sphincter control, my goodness. Girdle pain from spinal cord effects, and most common site for type 2, headache, visual disturbances, dizziness, tunnel vision, altered mental status, nausea, vomiting, vertigo, tinnitus. What is tinnitus? Ringing in the ears. Alright, and partial deafness. I have that constantly anyway. Like I constantly hear like a buzzing or ringing.
If it gets too quiet, my ears like freak out.
Yeah, that's like when I sleep, I have to have something going. If it's completely silent in the room, it's like a roaring.
I just hear a ring if I don't have a fan on when I sleep. That's just
Well, it's good to know that I'm not the only
yeah.
freak in the room.
I hear that.
Alright. Substernal burning sensation on inhalation. Non-productive cough. Respiratory distress. Alright. Symptoms can begin up to 12 hours following the dive and last for 12 to 48. It can have signs of hypovolemic shock, tachycardia, hypotension, formation of a thrombus from the activation of the blood coagulation system. When performing an assessment on the patient, the above can be seen in DCS. Fatigue. Signs and symptoms of shock, pupillary changes, pallor of the tongue, bloody sputum, nasal flaring, retractions, accessory muscle use. You also have tachypnea, crackles in the lungs, SpO2 less than 94, vomiting, urinary bladder distension. You can also have seizures, uncoordinated movement, weakness, motor and sensory deficits, joint pain, decreased range of motion, edema, cyanosis, pallor, itching, marbling skin. Alright, so we need to know, where did you dive? What was the depth? For how long? Other depths and times. Rate of ascent. Patient. What had they done since the dive? What did they do in the 72 hours before the dive? Did they do any work while they were diving? What gases were used? And did they have any problems during the dive? You also need to look at their overall physical condition before, during, and after. Okay? And was any first aid provided? Arterial gas embolus is an AGE. Is a blockage or a blocking of blood vessels by an air bubble or cluster of air bubbles. The blockage interferes with perfusion of body tissues with oxygen and nutrients normally supplied by the blood. The diver ascends rapidly while holding their breath. The air in the lungs expand rapidly, rupturing the alveoli and damaging adjacent blood vessels. As a result, air bubbles enter the bloodstream. Let me just tell you, air in the bloodstream, not good. Not good at all. Signs and symptoms of air embolus have a rapid onset and often appear within 15 minutes of the diver resurfacing. They will have itchy, blotchy, mottled skin, difficulty breathing, dizziness, chest pain, severe, deep, aching pain in the muscle points and tendons. Oh, I have that already. Blurred and distorted vision. Check another one. Partial deafness. Ding ding. Nausea, vomiting. Numbness, paralysis. Weakness or numbness on one side of the body. Staggering gait, lack of coordination. Frothy blood in the nose or mouth. Swelling, crepitus in the neck. Distortion of memory. It's like I can see it, I know what the word is, but I cannot make my mouth pronounce it. Coma, cardiac or respiratory arrest, and behavioral changes. Divers with upper respiratory infection or allergy are at increased risk of barotrauma. Signs and symptoms of the condition include mild to severe pain in the affected area, clear or bloody discharge from the ears or nose, extreme dizziness, nausea, disorientation. Patients suffering from barotrauma must be cared for at a medical facility to prevent permanent deafness, residual dizziness, or the inability to dive in the future. If any suspected spinal injury exists, take the necessary spine motion restriction precautions. Keep the patient in a supine position. If spinal injury is suspected or if the patient is alert. If the patient does not have a suspected spinal injury, has an altermental status, place the patient in the lateral recumbent, open the airway, assist for adequate breathing and respiration. If breathing is adequate, administer oxygen by a non-rebreather mask, 15 liters, even if the SpO2 reading is greater than 94. This is the only time you will do that. Oxygen is critical in diving emergencies because it reduces the size of the nitrogen bubble and improves circulation. Be sure to document the exact time that the oxygen was delivered. If the tidal volume or respiratory rate is inadequate, you need to begin positive pressure ventilations. Initiate CPR, apply the AED if indicated, if they're pulseless and apneic. Transport the patient immediately. If it is a diving emergency, try to obtain the patient's dive log and transport it with them to the hospital. Contact medical direction. To consider transport to a facility with a hyperbaric oxygen tank or an oxygen chamber. Okay, a lot of hospitals do not have these.
I'll be around
St. Francis probably has one. Glenwood probably has one. Yeah, they have wound care. They use hyperbaric oxygen with wound care a lot. The patient, 2-year-old girl, was most likely submerged between 5 to 7 minutes. There does not appear to be a reason to suspect spinal injury. Jacob is particularly concerned with providing patient airway and adequate ventilation and oxygenation. Opens the airway with a head tilt chin lift, places a folded towel beneath the patient's shoulder, suctions the airway, inserts the OPA, and we're still doing CPR. Lydia drives the patient and applies the AED. However, no shock is indicated. Jacob performs positive pressure ventilation with supplemental oxygen, but he finds that there is increased resistance to ventilation. The patient's stomach appears very distended, so the EMTs position her on her side and decompress the stomach, suctioning the airway, suctioning away the stomach contents to prevent aspiration. They immediately begin transport and request intercept with an ALS unit, pushing their 20-minute transport time. The patient regains a pulse prior to arriving at the emergency department, but remains unresponsive. She is admitted to the pediatric critical care, where she is carefully monitored for neurological damage and respiratory complications. Currently, her prognosis for recovery is uncertain. All right. Any questions? Yes, no, maybe.